Thanks for joining us, everybody. Cam's gonna give us a nice talk on MIS for trauma. So without further ado, go ahead and hit it, Cam.
All right. I'm Cameron. I'm one of the fellows here. I'll go through this. Here's a quick outline. We'll touch on some of the topics we've touched on before, like the classifications for the trauma, kind of thoracolumbar trauma and things like that. So we won't spend too much time on that. But MIS surgery was originally developed for degenerative lumbar conditions, but as time has gone on, we've used it for more and more things. The idea behind it is preservation of soft tissue, but still being able to accomplish what you need to accomplish, whether that's decompression, stabilization, or deformity correction. In the context of damage control or surgery or just trauma, where you're in a different environment, you want to minimize the damage you're doing to the patient as well. MIS can be useful. And then the main application that we see is the thoracolumbar spine. Thoracolumbar spine, but as we'll see at the end of the presentation, we'll talk a little about cervical trauma as well. Overall, 160,000 spine fractures per year, 160,000, and then more than 50% occur at the thoracolumbar spine, bimodal distribution, and then 26.5% of those thoracolumbar fractures involve the spinal cord. Most of these fractures are burst type fractures or wedge type fractures. And then in the polytrauma situation, as you can see here, a lot of these patients have other injuries, so MIS surgery can be helpful in kind of treating these patients. So different classification systems, and the main reason why these are in here is because when we start talking about the treatment logarithms and the newest recommendations, a lot of them go off of or use the baseline of the TLIG score, and then on the next slide I'll have the AO classification, but basically based on morphology, neurologic status, integrity of ligamented structures, less than 4, we say it can be treated non-operatively. Greater than 5, we say operative, and 4 kind of puts you in this middle zone. And then this is the AO classification system. So the most recent kind of and updated guidelines go partially based on this as well. And so it's broken up once subaxial C-spine and thoracolumbar spine. And that's what's shown here. It takes into account the morphology, neurologic status, and case-specific modifiers. And those will come into play in these kind of when deciding for surgery. And then just of note, there's a 2018 meta-analysis that kind of showed that TLIGs is still the more widely used and preferred method for most surgeons in terms of surgical decision making, but AO has better intra-observer reliability when you're actually looking at the grading. So just something to keep in mind there. But a lot of these you can implement both to help you make that decision. And so just on the, since we're talking about kind of these polytraumatized patients or trauma patients, with this MIS surgery, you can reduce the physiologic burden and morbidity associated with those traditional open results. So this is a paper from JVJS in 2006. It looked over 1,000 people, Level 1 Trauma Center, and risk factor for respiratory failure in spine patients. And the only physician-dependent risk factor that was associated with lowering of respiratory failure in polytrauma patients was stabilization of spine fractures. And then as advances were made in the MIS field, we found ability to do percutaneous pedicle screws, powerful reduction tools, and rod passage maneuvers that allow you to minimize the disruption, and that many injuries can be treated posteriorly. And traditional posterior approaches involve significant muscle morbidity. That was kind of the go-to, is just open approaches. And these two studies, or this study from Kim et al. Looked at the morbidity of the multifidus muscle in percutaneous versus open pedicle fixation by using MRI. And just to note, the pictures themselves show decrease in cross-sectional area of the muscle in the open group as compared to the percutaneous group. But overall, just to keep in mind, and there was no significant difference between the patient-reported outcomes actually between the two groups. But and then MIS, once again, it kind of makes sense, but decreases blood loss, shorter operative times typically, and shorter length of stay than traditional hospitals. Various studies have shown this. It's also, in this study, they showed it lowered the post-operative pain and improved functional recovery within 3 months of surgery. So here are some further comparisons. So this was a comparison of the PERC versus open, and this was 100 minimally invasive cases versus 155 open cases. And once again, they came to the conclusion that the advantages for treatment of thoracolumbar fractures is decreased operative time, decreased blood loss, and fewer patients requiring transfusion. And then this was just a Congress of Neurologic Surgeons systematic review where they looked at does arthrodesis to the and this will come into play when we're kind of talking about what methodology used to treat these and whether you need to fuse them or not. But in these, they used 2 level 1 studies and 3 level 2 studies, but they recommended in surgical treatment of patients with the burst fractures that surgeons should understand that arthrodesis in addition to instrumentation has not been shown to impact clinically or radiographically the outcomes on these patients. And so now we'll kind of keep jumping into the this was kind of the rationale. Once again, the MIS rates include, even with a simple decompression, they had better surgical outcomes. And then once again, that the infection rate at the site for open was about 2 to 6% quoted. In the MIS group, they found it to be significantly lower at 0.2%. And so indications for these, and that's the main thing that kind of delve into and look at is, you have to take into account the bony and ligamentous injury pattern, presence of neurologic injury, and then also when you get in these patients, you don't get to pick and choose who's coming through the door with these, so you don't get to have BMI restrictions or anything like that. So that's another consideration, and you have to be comfortable doing this. And so the basic indications still apply for fracture fixation. But these can be useful in these unstable fractures. And traditionally, I think, and we'll see in the studies that without spinal cord injury, flexion extension distraction injuries or unstable sacral fractures are kind of the caveats to that. But we'll kind of talk now about when and why you should be using this. And then obviously, big conjugation, if you can't see well, you can't do MIS, so you need to take that into account as well. So the question of do you need to fuse? This was a study had 23 patients under the age of 40 managed with pedicle screw fixation, and they had their implants removed at about 10 months. And overall, fracture heights were maintained as well, and they had good functional outcomes. And then this is the second study. Just notes that it was a systematic review, like we talked about earlier, that arthrodesis did not improve clinical outcomes, and it was associated with increased surgical time, higher bleeding, and did not significantly improve the radiographic parameters. But you still have to apply this in specific patients, and like I said, as we go to the newest recommendations, we'll kind of hash those out. And then removal of the instrumentation is another question that people have after you do these surgeries. A lot of people like to take them out. This study notes that removal of the instrumentation, previous without instrumentation provided high patient satisfaction, mild pain, and minimal disability, and relieved the patient from the burden of the financial stresses and need for a second surgery. So, but this is a controversial topic, and I know I was going to kind of ask the attendings at the end kind of what everyone's thoughts are on that. And then this is just a more for when you're starting practice or your comfort level with MIS, if that's not what you trained in. This study showed that after about your 30th case is when you see a reduction in your complications. So, once again, you have to take these into account, that there's a learning curve associated with this if it's not something you practiced much. And then this was a retrospective CT study of percutaneous screws for accuracy and complication. And the thing is, the failure to achieve radiographic visualization is a contraindication. And then this was looking at how accurate you are. And so in MIS study, they had about 9.7% of pedicle screws from malposition. And the area that was the hardest to see, which was L3 to L5, because you have interference in the iliac spine, was where you saw most of these. And then furthermore, the understanding that if you do an MIS case, for the most part, you can always have a higher radiation dose, and this study, when they looked at this as well, they report up to 10 times as much radiation with compared to traditional approaches. So now, indications, current guidelines for this. There's some previous recommendations. So in 2014, and this study is the most updated kind of recommendations that we'll go through. But looking back previously in 2014, they noted that the patients with burst fractures, DISH or AS, those were the only patients that should be treated with this percutaneous fixation without fusion. And then in 2019, as we kind of looked at those guidelines, they found in the Congress of Neurologic Surgeons that there's no benefit of open surgery or surgical arthrodesis compared with percutaneous fixation alone in the thoracolumbar burst fractures. And then once again, the removal of instrumentation at 12 months. A lot of people in this guidelines recommended only removing it if the patient was symptomatic. And then we will, the current recommendation regarding arthrodesis is from this study was anytime you do a decompression, that you should include an arthrodesis as well. But they note that further studies should explore whether you can do a decompression and do percutaneous stabilization alone and have that be fine. And then kind of a general guideline for the percutaneous fixation only patients with TLIC score of 4, which kind of falls in the AO spine subtype of A3/A4, or those with DISH, ankylosing spondylitis, or a bony chance fracture, not a ligamentous chance fracture. So these are the diagrams and how they would treat these various things. So the first one here is just general. If you're a TLIC's less than 4, or an AO classification AO 0 to 2, and your neurologic status N0 and 1, observation with or without a brace, that's your preference. The TLICS 4s, which is the AO 3 to 4, follow in this surgical stabilization needed, and we'll go to the next slides and kind of talk about that. And if yes, they get bumped up into this category, and then that's when you decide whether you can do from this perspective, MIS versus open, and what you need to take into account if there's substantial distraction, past instrumentation, or if it's a higher AO type, the AO type C or AO type B, then you have to recommend open treatment, but anything else can fall in this MIS treatment category. And then this is kind of their categories here. So now we'll go into those. So this is the AO34. So these are the ones that there's a question on, the ones that you're kind of trying to figure out. So AO34, TLICS 4, or if you're looking at the McAfee classification of burst without substantial PLC injury. So if you have any type of neurologic deficit that's kind of N2 to 4, then yes, you get this, and there's substantial vertebral body compromise. Then if no, you can do a MIS posterior arthrodesis mini open decompression. If yes, if there's significant vertebral compromise, then they recommend either anterior or lateral type MIS approach for reconstruction, cage placement, and then arthrodesis and posterior stabilization. If you don't have any of these, then and you still need, but you don't need surgery, you can still treat these non-operatively, and so that'd be a brace. But if you do need surgical stabilization, then you have to look at it and see if you're at type A4 with significant body compromise. That kind of pushes you down once again, considering going lateral or anterior and being able to decompress from the front and put a cage in, versus if no, you can just do MIS percutaneous stabilization only without an arthrodesis. Now for the higher grade injuries, so AOB or TLICS greater than 4, it's just, and then in the McAfee classification, distraction injury, burst fracture, PLC injury. Once again, neurologic status is kind of the first thing. If you have neurologic injury, then yes, you can do substantial. I mean, if it has substantial vertebral body compromise, then once again, you kind of go down the anterior lateral reconstruction pathway. If not, then the posterior. And then this is when it comes to play some of these questions, because these are TLICS greater than 4. But if you have no neurologic deficits, if you have a type B1 or B2 to 3 with ankylosing spondylitis or DISH, then yes, you can still treat these with MIS percutaneous stabilization only per the recommendations. If you have substantial vertebral, if you don't have this and you have substantial vertebral body compromise, then no, and you don't have that, then you can do a posterior arthrodesis only. If you do have substantial vertebral body compromise, then you have to do, once again, anterior lateral reconstruction and arthrodesis. And then the difference here is that in this no group, when you compare it to the TLIX 4, you can just do MIS percutaneous stabilization, and these ones, they recommend arthrodesis as well. Now, there are studies that are now trying to see how you can apply this to these higher grade injuries, because that's the obvious next question is, you know, if we're just trying to push the boundaries of this and when you can do it. And so this was a study looking at patients that averaged a TLIX score of 7.5. And in this study, they had fairly good results in all of their patients, and they fused, you know, the typical number of segments instrumented was typically about 2 above and 2 below. And so when they finished this, they kind of even talk about doing unilateral fixation within this study. And so their kind of recommendations for unilateral fixation in these high-grade injuries, they actually, in their study, did anyone with a TLIX greater than or equal to 5 with no significant translation or rotation with good pedicles, then they thought that you could do unilateral thoracolumbar instrumentation for these, and they had good results. So just a lot of the studies now are trying to, like I said, push these boundaries and look forward. This is another one that kind of looks at these more high-grade injuries, a systematic review where people are getting fairly good results with these MIS procedures compared to open procedures for these. But like I said, the most recent recommendations are, this is kind of the most updated treatment algorithm, so, and they don't recommend for that, but this is just kind of things on the horizon. Another tool to have in the MIS kind of back pocket when you're considering trauma is the lateral approach. This allows you, like you saw from one of those diagrams, when you have neurologic injury, you need to do a decompression from the front, or you have vertebral body compromise. This is kind of the go-to for that. And so the main goals would be anterior column support to achieve that with expandable cages. But obviously there's complications that come along with this, but like I said, a powerful tool in the right setting. This is a kind of study of prospective registry data that from the start in 2010. They had 52 patients treated with mini open lateral approaches for corpectomy and then fixation posteriorly, and all these patients did fairly well. They had fairly good results from these. So this is kind of a good paper showing, going through that, how to do that. And so ultimately your goals with these should be to achieve neural decompression, reconstruct the spine and stabilize it. And then you're minimizing the typical approach-related morbidity with pneumo, hemothorax, post-thoracotomy syndrome, vascular injury, incisional hernia, and ileus. And it also allows you to reduce your blood loss, length of stay, and opiate use and complications. And so this is just more probably something I just need to send along to Amber, but a good paper on the kind of nuances of MIS lateral approach for these burst fractures. So I just put it in here, but more for me to have that paper in my kind of saved papers. And then another thing is from thoracolumbar spine area is the kind of cement augmentation or kyphoplasty. And so you can use these for these low energy injuries. Cervical trauma, not as much as this. There's not a lot of set guidelines or innovations, but there are a lot of people looking at how MIS surgery can be applied in the cervical spine. Obviously a little more difficult to apply it in the cervical spine currently, but what you do see is a lot of people using it for the treatment of C1-2 injuries. And so this is a study where they had 7 patients, and they were attempting to do MIS, transarticular screw fixation, and microendoscopic bone graft for atelectaxial instability. And so they did like microendoscopic procedures. You can see kind of through these pictures here to prepare the C1-2 joint, and then and they used navigation for that, and then they placed bilateral transarticular screws anteriorly with a percutaneous approach only. And this is kind of showing how they plan those out, or what your windows are for placing those screws. And in these patients, they had decent results. Obviously, a very small subset of patients. 2 of them still had dysphagia, but they were trying to show that this is feasible. And then, kind of in that same thing is treatment of antoaxial fusion, or MIS antoaxial fusion. This was 5 clinic 5 cadaveric study reports. And so they kind of go through a technique of using 3 centimeter paramedian incisions, and then 2 protractors and dock to the superior aspect of the C2 lateral mass, and using BMP and a cross connector through submuscular tunnel. So there's not as much in the cervical spine, but there's people attempting to kind of make it more and more realistic. So overall conclusions, techniques, they're advancing. And like I said, as we kind of get a better grasp on this, we are trying to push the limits of using MIS specifically in the thoracolumbar spine, but in the cervical spine now. The main idea behind this is decreasing morbidity involved with traditional open approaches, but you have to be comfortable with this. You have to be able to see what you're doing and know what you're doing, and so imaging is important, and surgeon comfort level is important. So sometimes in the hands of some people, open might still be better and safer, even if it has a little more blood loss and things like that. But being able to do these is really important, and having a good algorithm for who you're treating with that is good. And so this kind of paper, the most recent one, kind of with updated management, is pretty good and touches on all those topics kind of listed here. So it's just a good paper in general. So that's all I've got. And then I don't know if attendings had anything to add.
Nope, great summary.
Thanks,
So,
Ken.
still a little paucity of literature out there, but it's definitely a role for it.
Now, do you like to take, if you're just doing perk, do you like to take them out at a year? Like I said, I was listening to various talks, and it kind of goes both ways.
I generally do, but I don't know that that's right. It just I have a orthopedic obstruction to one of the lead station across joints that I intend to have moving.
Agreed. Yeah, I was surprised there was as much stuff saying you can just leave it in, but
yeah, I don't quite get that, but there may be some neurosurgery, orthopedic surgery delineations there. What do you think, Don, Annie?
Yeah, I think if you're just doing perk, it's very reasonable to take it out in a year. Absolutely agree.
Yeah, it's funny, Bob. I see a lot of patients who've come in who've had, open treatment for fractures that they have them diffused, but they leave them in and they remarkably aren't terribly symptomatic. Some are, some aren't. It's a weird phenomenon, right? You've got this 2 above, 2 below, or whatever. There might be 3 above, 3 below, and they're not fused, but they don't have symptoms. So I take instrumentation out of most everybody just for the stiffness issues. And I agree, you want to maintain joint preservation if you can. So that would be my feeling as well, if you're not going to fuse them.
And then I just think historically, a lot of these trauma patients end up lost to follow-up, because they get sent in from tertiary or smaller centers to tertiary care centers, and, they go back to their communities and they don't follow up beyond a year.
Yeah, that's a good point. Or they just don't follow up.
Yeah, or even in San Diego, we always would take care of the Kaiser traumas, and then they would fall back into, Mike Flippin's lap. So, usually beyond the 12-week episode, they end up assuming care. So,
Yeah, that there's something to be said for the socioeconomic group that's in those traumas. There's often not a follow-up route for them, insurance wise.
yeah.
That's probably a good portion of them. Well, cool. Thanks for presenting that, Cam. Any other input, questions?
that's it. Thank you very much. Have a great week, everybody.
You too.
Thanks. You guys
Bye.
take
Thank
care.
you.